Well, good morning. My name is Dr. Alan Lumsden. I'm the chairman of the Department of Cardiovascular Surgery and the medical director for the Houston Methodist DeBakey Heart and Vascular Center. So welcome to the Heart and Vascular Center Grand Rounds. We have a very distinguished speaker this morning, someone I've known for many years and is one of the most preeminent academic vascular surgeons, in the United States and in the world. And so we're joined today by Dr. Ron Dalman, who's the Walter Clifford Chidester and the Elsa Rooney Chidester Professor of Surgery and Chief at Stanford Vascular Surgery. Ron also serving as the current president of the Society of Vascular Surgery. And you can imagine it's been a challenge leading that society in this tumultuous year that we've actually had. But we're delighted to know that we're going to have an in-person vascular annual meeting in San Diego in August this year, and Dr. Dalman will preside over that. In addition to presiding over our society, he's also directed the Stanford Vascular Surgery program since 2005. And it comprises 18 medical and surgical faculty. In fact, he incorporated vascular medicine into that department as a very distinguished representation from vascular medicine. And they provide diagnostic and surgical services at 8 locations in the greater San Francisco Bay Area of Northern California. Dr. Dalman recently got awarded an NIH grant looking at metformin and how it affects the growth of aneurysms, and that's really been a focus of his interest in studying the pathophysiology of abdominal aortic aneurysmal disease, and he's actively engaged in identifying and validating these new methods for treatment of AAA. But he's got a bigger role than just being the chief of vascular surgery, because at Stanford Medicine level, he serves as the associate dean for market development, as well as the co-director for the cardiovascular health destination service line. So he's going to talk today about the secrets of how to become a successful academic vascular surgeon. Ron, all I can say is I wish I'd listened to this 30 years ago, so I'm going to be able to identify all the mistakes that I've made down the line. So Ron, I'm going to turn it over to you. Thank you very much. We promise we'll still get you down here in person sometime in the near future. Thank you for doing this.
Thank you, Alan. Good morning, everybody. It's my honor to be giving grand rounds at Houston Methodist this morning, and I appreciate very much the invitation. I thought this would be a good opportunity to talk about some of the challenges that we all face in trying to develop our careers. Each are different, obviously, in their own ways, but on the other hand, there's some commonalities in terms of challenges and ambition, etc. And it's worth thinking a little bit about how experiences like mine might provide some guidance for others. I have no specific disclosures for this presentation. As Alan mentioned, I just completed my year as 75th president of the Society for Vascular Surgery. And as of next month, I'll be stepping down as division chief of vascular surgery as well after 16 years. So I have some background to consider. So this is our group at Stanford Vascular Surgery, a pre-pandemic picture. In this picture, I've hired everybody in this group. And as Alan mentioned, we are a regionally kind of large group in Northern California. And we've been very fortunate in our opportunities to provide care for patients in our area. It's a large group now, but it wasn't always that way. And so I think it is instructive, as I said, to think about how do we get here and what decisions did we need to make along the way. So Stanford was a little bit late to vascular surgery as a distinct specialty. When I started on the faculty, vascular surgery was done by the cardiac surgeons at Stanford. So we were relatively late to the game as a distinct clinical specialty. Our division was founded in 1991. Dr. Zarens and Fogarty were recruited in 1993. Chris then became the division chief for the next 12 years. Our first fellowship trainee was in 1994. And in the FDA approved endovascular grafting for abdominal aortic aneurysms in 1999. Which Stanford had a leadership role in that process. So we'll talk about that in a minute. This diagram is from Dr. Fogarty's patent for embolectomy catheter. So the 90s were an era of significant growth and kind of evolution of vascular surgery as distinct specialty at Stanford. Some of our benchmark outcomes we reported during that decade were low mortality for open repair as kind of a comparison for what was to come with EVAR. John Harris and I reported on 100 or nearly 100 consecutive open aneurysm repairs without death, and also benchmark outcomes for other signature operations in vascular surgery. And then perhaps one of the most significant was the first demonstration that EVAR lowers aneurysm-related mortality by Frank Arco. That was published in 2002. So in regards to the history of EVAR, all three of the original FDA-approved U.S. endografts in the United States were developed in part by inventors and investigator teams at Stanford. And Cure Device was John Stevens and Wes Sterman were significantly involved in the development of that device. The Anurex device, Chris Aarons, Tom Fogarty, and the excluder device was leveraged off some patents in a previous company that was founded by Mike Dake and others. And so we have that background from which to work from. And recently, in 2017, we celebrated the 25th anniversary of the first placement of endograft in the United States, a series of which was subsequently published in the New England Journal in 1994. And Mike invited many of the luminaries of the era to Stanford to celebrate this important anniversary. So when I started on the faculty, when I started as division chief in 2005, there was it had been a big kind of transition. A few people had left, and a few people were retiring, and so we had a total of 6 faculty at that time, covering 2 hospitals with 1 fellow. And as a new division chief, I could only get 4 people to show up for the faculty photo. Now, as Ellen mentioned, we're actually working in 7 facilities. We have 17 clinical faculty, 4 trainees a year. This is our faculty composite. Also, I think in a large health system environment, competitive environment, we compete with Kaiser and UCSF, other health systems in Northern California. If you're not growing, you're actually shrinking, only in this concept of market share. So our health system decided, early in this century that we needed to become more regionally diversified and, bring care to the patients, basically. So we have vascular surgical practice locations all around San Francisco Bay Area. In fact, until a year or 2 ago, we actually had a contracted vascular practice at Marin General Hospital in Larkspur, California. And these are just example of some of these facilities. Wound Care Center that we manage with plastic surgery in Redwood City. Our new hospital, it opened 2019, 800,000 square feet, $2.2 billion. Our Department of Veterans Affairs Hospital in Palo Alto, County Trauma Center, the 2nd largest county health system in the state of California. Pleasanton, we bought a hospital, Valley Care, which is now the anchor of our practice in the East Bay. And we have a medical office building with 4 operating rooms, including a hybrid operating room suite, Siemens hybrid operating room suite in Emeryville, California. So in addition to, regionalization of the practice, there were also just compelling needs in terms of the type of care we provide for the patients in our area. So this is complex EVAR endo. This is an endograft after a cheese wire septectomy with placement of a thoracic extension piece at the now single lumen and a chronically dissected aortic patient that we basically had converted this into a single lumen where we could then perform an exclusion, aneurysm exclusion. This is a branched artery aneurysm of the humeral artery and a professional overhead throwing athlete with digital embolization. This is, we have a large athletic vascular practice. In this case, we're talking about a neurogenic thoracic outlet. This was a story of a student at Stanford who was on the diving team, and by the end of his first year, couldn't raise his arms above his head. And after a thoracic outlet procedure for neurogenic thoracic outlet, he wound up as an All-American and captain of the diving team. There were needs that had been present, but we just didn't have a good structure to address them. And so one example would be this wound care program. This is directed by my colleague, Dr. Vinita Chandra, in vascular surgery, and co-managed by our colleagues in plastic surgery. This is, as I said, in a separate location in Redwood City, where we have hyperbaric capability, but also in the same facility, there's infectious disease, dermatology, podiatry, orthopedics, rehab, pharmacy, and all the components necessary for a comprehensive wound care program, which has made a big difference in our practice. We'll talk about that a little bit later in the presentation. So one of the challenges for us, in our system, our region, is just our costs are high for many reasons, and it makes it hard for us to compete in some circumstances. And also, as the nation's healthcare financing kind of paradigm switches from volume to value, we need to be able to demonstrate that we can control costs and increase efficiency and value. And so, interestingly, with the integration of this wound care center into our practice, it's actually dropped our costs significantly for DRGs related to lower extremity limb salvage diabetic foot problems, primarily because of reduced readmissions. So, for example, this is some Vizient data, and you can see that costs less. This is a national. This is our average adjusted cost score. This is national average. It's costing us less to take care of these patients, primarily because, the real reason is because reduced readmissions. So by partnering with this wound care center, when these patients are revascularized, they've had a partial foot amputation, debridement, whatever needs to be done, they get their care then gets transferred to the wound care center, where they get weekly visits for pain management, debridement, antibiotic adjustment, that type of thing. And so that's made a huge difference in our costs. So you can see, even though the wound care center itself increases costs somewhat, the savings from avoiding the readmissions and the reoperations and those things vastly outweigh the cost of the wound care addition. And so we were actually pleased to find that we have a 13% below national average for the cost of these patients. As I mentioned, this program is directed by my colleague, Dr. Chandra. And you can see that compared to our peers in the state of California, our length of stay index is quite low. Our case mix index is competitive. Costs, as I said, are relatively low. And this is the most remarkable data point of all, less than 10% readmission at 30 days for these patients that typically across the country will experience 25-30% readmission at 30 days. So we've had to develop other new programs, such as, helping the healthcare system develop an NIH-designated stroke center, complex cooperations with general surgery, surgical oncology, ortho-oncology, other specialties within the hospital, spine surgery, as well as kind of build out areas of existing expertise, such as management of aortic aneurysm disease. And we can see here, based on California data from the Office of Health Services and Planning, or OSHPOD is what it's called. If we look at both standard EVAR and complex EVAR, Stanford's volumes are the highest in the state. Our length of stay index is very competitive. Our case mix index shows the patients are, quite ill and comparable to those of our peers. And like everyone, our practice has evolved to primarily an endovascular management paradigm. This year, we'll cross a threshold of 200 aortic procedures for both dissection and aneurysm. But we continue to have a significant component of open procedures. But this is kind of an evolving picture. One example of a care process or pathway that we needed to develop in the evolution of our division over the last decade and a half was a kind of a standardized approach to rupture aortic aneurysms. I think we all understand that EVAR plays a role in that, but it's not really just EVAR. It's actually having a system in place where we anticipate that these patients will come, what their needs are, and we have protocols in place to try to basically get the graft placed as quickly as possible. So our goal in these cases is to try to get the endograft placed within an hour. And for several years, we actually had a industry-sponsored course to kind of go through the necessary steps to achieve this. This, for example, shows having an occlusion balloon in place to get bleeding under control while the main body is being deployed. This is an example of a representative case where we had all devices in place within 44 minutes of the patient coming to the operating room. And so, again, as I mentioned, it's really the protocol. Having a single page goes out to anesthesia, cath techs, blood bank, operating room, having all the devices in place, going through, mock patient kind of transfer and, resuscitation scenarios. And if we look at our outcomes before and after adaptation of this protocol, we can see a significant improvement in survival. And that, again, is kind of a challenge that we needed to address just based on the regional referral nature of our practice. We've had to develop new techniques to manage complex thoracic aortic and abdominal and thoracoabdominal aortic aneurysm disease. Of course, we're participating in the TAMBI trial, and we have access to all approved FDA devices, but still scenarios come up where we need to come up with custom solution for patients. And here's an example of an octopus case that can be helpful to manage these complex aortic anatomies. We live in the Western United States, and so for us, the issues are not just local and regional to Northern California, but across the West, there's questions about just the distances that people have to travel for care. It's not unusual for us to accept transfers from hundreds of miles away. And so within the Western Vascular Society, we developed kind of standard transfer protocols to help understand what is the trade-off of having someone transferred, for example, aortic emergency, what's the mortality associated with the transfer itself, as opposed to trying to do the best you can for the patient area. And Matt Mell, when he was on our faculty, he led this initiative with the other academic centers in the Western Vascular Society. And as I said, all these elements help us perform well, both in the care we provide for patients, as well as outcomes assessment of some of the quality and analytic systems we participate in. So you can see on Divsion, for example, in recent years, our O2E observed to expected mortality has been very competitive with those of our peer organizations. The benchmarking part has been important and has helped us really understand where improvement opportunities really lie. This is a project that we did with VQI at the PSO, the Society for Vascular Surgery Vascular Quality Initiative. We are one of the 18 highest EVAR performing sites in VQI, which now has over 800 health systems or hospitals and includes over 800,000 procedures. And if we look at our peer institutions within the VQI, green bar being standard EVAR without complication, blue bar complex EVAR without complication, yellow standard with complication, and complex with complication. We see that on this chart, Stanford is A, which puts us near the top of this group. And actually, we use this information as part of an EVAR cost demonstration project with a company called MedStreaming that provides proprietary cost to charge ratio data. And we learned that our costs were very, very high compared to other organizations participating in this. And we use that information to significantly reduce the costs, the prices we were paying for endografts for these procedures. To have a successful vascular practice, it takes obviously more than just the surgeons. We had to develop a team, and that includes new patient coordinators, surgery schedulers, academic staff, RVTs, MAs, APPs, as well as obviously OR staff, cath lab staff. And so we've been fortunate to be able to build out a really highly functional and competent team to help us kind of manage our growing practice. And it's important as well to engage stakeholders and complementary specialties within your health system and help them understand what your needs are and help them develop the resources necessary to help you, basically. And so we're really fortunate at Stanford to have world-class imaging that helps us both plan our procedures and follow patients after the procedure's been performed, as well as understand the natural history of the disease. Just as an example of some of the post-processing that's possible with our colleagues in radiology. We've had the good fortune of being able to train a really capable and really dynamic group of aspiring vascular surgeons, and we have a high interest in our training programs, both integrated and the traditional fellowship program. We were one of the first 10 integrated vascular residencies in the United States, first in the west of the Mississippi. And we're quite pleased and proud of our training cohort and what they've been accomplished, what they have accomplished with us and what they've accomplished in the years since finishing our training. Part of our integrated residency includes 2 years of mandatory research that's funded through T32 that I was principal investigator for 10 years up through last year, and then transitioned to another faculty member in our division. And so this T32 is actually centered in our Cardiovascular Institute rather than the Department of Surgery. And the Cardiovascular Institute extends across the university. It has about 230 faculty and 60 some different academic units of the university, including departments and divisions. So regardless of the interests of our trainees, whether they're in genomics or gender and ethnicity differences or bioengineering or vascular regeneration, tissue development, we can find a laboratory and mentors and projects that are of interest to our trainees. And so we found this to be a great help in terms of career development activities. And our research itself includes both clinical, such as exploring new combinations of endografts that are optimal for patient outcome, translational, looking, for example, at failure modes of branched or fenestrated endografting, understanding some of the forces involved with respiratory and cardiovascular motion to predict branched failure, and try to think about how to modifying the device or how we perform the procedure to minimize these risks. And actually basic translational or basic, mechanisms of disease. This looks at efferocytosis as a driver for atherosclerosis, and looking at this CD47 ligand as a promoting biomolecule for progression of aortic aneurysm disease. And in fact, one of our faculty, along with colleagues at Stanford, recently created a company called 47, which was purchased by Gilead for several $1 billion, and is transitioning this to both effective clinical treatment for cancer applications, as well as hopefully someday in the future prevention or medical treatment of atherosclerosis. It's also important in surgery and for the health system and for the kind of the sense of purpose and opportunity for our faculty to have a growing clinical practice. And so over the last 10 years, we've been fortunate to have year-on-year double-digit increases every year in percentage of RVU productivity. That's also been an important goal for us. And then finally, it's at Stanford, at Methodist with Dr. DeBakey, at a few places in the country, the expectations are high in terms of what you can accomplish or what you're supposed to be working on, or we are fortunate to have resources and to have a health system which is very supportive of our practice. And so here's Tom Fogarty receiving a National Medal of Innovation from President Obama. So just in case you think you're doing well, you can look back at some accomplishments of your predecessors to encourage you to continue to try to improve your outcomes and efforts. So that's been my experience at Stanford. Some of the things, the challenges we were presented with, and some of the kind of systems we developed to address some of those. But, what generalized lessons can we draw from experiences like mine? So I think, there are really just a few fundamental principles in academic surgery that are relevant, regardless of where you are, or more or less what the challenges need to be that need to be addressed. I think you have to be quite confident with what your own personal goals are, know what the system expects of you, align your goals well with whatever the expectations are, collaborate aggressively across the whole institution, not just within the groups you're familiar with, optimize your personal network, and we'll talk about what that means. And then finally, particularly as vascular surgeons, I think we need to own the problem. We can't really just be seen as technologists, procedure specialists. We have to kind of be holistic masters of the problem. And that's SVS has the hashtag comprehensive vascular care, which I think nicely kind of encompasses that concept. So know yourself. So it's important in our faculty that everyone is pursuing the things that they're most interested in. There's not a single example of what it means to be an academic vascular surgeon. So my colleague, Dr. Jason Lee, for example, likes to work in device development and complex aortic reconstructions. That's great. Elsa Ross on our faculty is a bioinformatics expert using natural language processing and AI machine learning to extract important data points from unstructured medical records to improve screening and make sure patients are meeting, recommended therapeutic goals across the health system, not just the ones that are already in our practice. Oliver Alami in our faculty is interested in remote monitoring and wearables. He's associate director of the Biozyme program at Stanford for wearables, and he has been the primary driving force behind developing the SVS branded supervised exercise therapy app, which is now sponsored by Anthem Blue Cross. The idea being that we can monitor whether patients are exercising sufficiently, and we can get a better idea about real world outcomes. So if we do an intervention and we see the ABI goes up, okay, we ask the patient if they're walking farther, there's a placebo effect, but can we really track exactly how much their activity has changed since their procedure to get a better idea about the value we provided for that intervention potentially? Dr. Shipra Arya on our faculty is an expert in frailty and preoperative risk assessment, which is extremely important in vascular surgery. As I mentioned, Dr. Chandra is looking at how to leverage these resources like wound care programs to improve outcomes for patients with, diabetic foot problems. Dr. Leeper is a discovery level scientist who, is really kind of pushing the boundaries of what we understand to be the cause of things like atherosclerosis. So point being that everybody's thing is a little bit different, but in the aggregate, they're all succeeding in their interests. Know what's expected of you. So at Stanford, as I said, we have a high expectation for faculty. This is on the first floor of the School of Medicine building. Since 2007, I think Stanford faculty have won 5 or 6 Nobel Prizes in medicine and chemistry. And we're not winning Nobel Prizes in vascular surgery, but if you look at what the dean puts out, for example, our preeminence metrics, you'll see that this is listed. It doesn't say specifically, but this really is listed in priority. You can see that total research expenditures, direct costs, National Institutes of Health total awards. The health system prioritizes and the school prioritizes these metrics at the very top of their preeminence assessment. And so if you're going to be at Stanford and you want to develop a faculty career here, you have to have a credible research background, a passion for research, to be able to understand how you can develop your research opportunities within the organization, and that's expected, and you have to understand that if you're going to succeed in this environment. You have to align your goals with the organization. So as I mentioned, there was an imperative. It's been now 15 years or so that we're going to become a regionally diversified health system. As I was telling Alan before the grand rounds. In the beginning, we were buying hospitals, and then we decided that with the transition to outpatient care and all kinds of uncertainty about healthcare financing, maybe strategic alignments would be a better way to kind of diversify regionally. And so this is an example of a health system in Reno, Nevada, renowned. It's a 700-bed hospital. It has its own, it has over 100 residents in a variety of different residency training programs affiliated with the University of Nevada, Reno. And Stanford has partnered with them on some very specific health kind of care categories, such as liver transplantation, other areas. And so, it's a long way from Reno to San Francisco. There's a 6 a.m. flight. Could go there. You come back in the evening, whatever. Point being, you could say, look, I don't want to go to Reno. I'd rather just take care of patients around here. But if the health system feels this is an important effort, then we need to try to find a way to meet those needs. And we negotiated with Renown. And, in the end, we actually, we did not launch a joint vascular program, but we made an offer on that and we negotiated that contract. We responded to the need of the health system to talk to these people, and that's expected. And if you're not comfortable with that or you don't want to do that, then this isn't really the right role for you in the right location. And because of my willingness to pursue a lot of these opportunities, the dean said, well, why don't you do this for the whole health system? So I started that job a couple of years ago. The collaboration part is important. It's typically for surgeons, a lot of the collaborations we have are within the Department of Surgery or maybe in a few closely affiliated departments. But it's interesting to think about what opportunities exist across the university environment. It's even outside the School of Medicine. How can we leverage unique opportunities to really make important contributions? And we had Elias Rooney from the NIH at Stanford a few years ago at the School of Medicine Leadership Retreat. And he was talking about one of the things that made research grant applications from Stanford unique and competitive is they brought unusual collaborations, like between medicine and engineering, to projects that other places didn't. And this idea that we could take some advantage from the broader academic ecosystem is an important concept, which is something that I've found to be very helpful in my own research interests, as well as that's kind of a characteristic feature of working in this particular organization. And it's something to think about when you're trying to develop your own research program. So here's an example of that. A few years ago, we had a prospective randomized controlled clinical trial looking at the role of supervised exercise training in preventing early abdominal aortic aneurysm disease progression. The title of that was AAA STOP. It was a program project grant, P50 program project grant. I was the PI on that. And in the course of that trial, we collected buffy coat and plasma from hundreds of small aneurysm patients. And so, working with Mike Snyder, who's chair of genetics at Stanford, we developed this kind of algorithm for using both genetic and environmental risk factors to predict, who's going to develop abdominal aortic aneurysm disease and how do we identify them in the population at large. And this resulted in a publication in Cell a couple years ago. And so the idea is that, not collaborating with somebody in genetics isn't necessarily the first thing that would come to your mind if you're a vascular surgeon typically, but it's these type of collaborations when you seek these people out and can kind of help them understand what your interests are and why it would be advantageous to them that can really advance, the contributions that you can make can move them to another level. In terms of optimizing human networks, so this Matthew Jackson is a economics professor at Stanford. He talks about just basically how organizations succeed. And one example he uses the Medici family in medieval or early Renaissance Florence and how they succeeded compared to their peers. And it turns out that if you do these little diagrams about these family connections at that time in Renaissance Italy, that, even though in the beginning it was a little bit challenging, through marriage and other economic kind of interests, the Medicis had more connections than anybody else. And the take-home point is it's not really who you know, but of the people you know, who do they know? And what are those second and third order connections? And that can be extremely helpful in a large organization like a research university. And I've found that to be the case in my own experience. And so one example of that is at Stanford Cardiovascular Medicine Institute, which is non-departmental and actually extends across the entire university. And so being involved in the leadership of this has really been helpful in helping our division find new opportunities to grow interests of our faculty. You know, when we talk about optimizing our network, we have to think a little differently, I think, here in the 21st century about what that network actually constitutes. So this is a picture of our group here of the year 2000 when Frank Arco finished as a vascular fellow. Fairly homogenous in terms of ethnic, racial background, and all men. You know, and Daniel Pink talks about this drive in his book Drive about autonomy and mastery and purpose. You know, those are all kind of Western concepts about what it takes to be successful when we look for somebody who has passion. But actually, you know, in different societies around the world, people think differently about why or what they want to accomplish in life. And so this Tara Yasu, she's a professor at UC Berkeley, asked this provocative question: whose culture has capital? You know, immigrants bring a lot of strengths to projects and to academic endeavors, any type of professional activity, just basically their experience with resilience and persistence and adaptation, that type of thing. And this paper was by one of my faculty colleagues, Dr. Marcus at Stanford, talking about passion matters, but not equally everywhere. If we look around the world, you know, it's not always about passion in the Western sense. It's about more collaborative experiences with extended family and other people in your social group. So I think, you know, thinking differently about who can contribute and what they can contribute can really help you advance your group. It's also true that, you know, this idea about imposter syndrome and, you know, why so many men become incompetent or why so many incompetent men become leaders. You know, there's lots of different ways to think about who can contribute to your group. And I would encourage you to think more broadly than might be comfortable in some of these circumstances to find the next great contributor to your organization. And then, as I mentioned, you know, you have to own the problem. We can't just be technologists. So part of this AAA STOP program was to understand the pathophysiology of abdominal aortic aneurysm disease rather than just whatever is the next best device to stick in an aneurysm. And that, I think, will help us as a specialty maintain leadership in this area rather than, you know, just hitting the RVU meter, which is important, but it's not all there is to it. So when we talk about leadership, you know, there's really just a set number of principles, and there's lots of books on this topic, and I don't have any particularly unique observations, I don't think, but I have found in my experience that being transparent, having integrity, leading from the front, you know, every one of those locations that I showed you on the map where we're working, I've worked there, I've had clinic, I've had hospital privileges there, I've taken call there. I don't ask the faculty to go any place that I'm not familiar with intimately, so I can understand what the challenges are in practicing there. You have to be responsive. You have to understand what are your assets, how can you leverage them, when do opportunities come up where your group is well suited to take advantage of those. Sometimes you just have to completely reset when things aren't working and acknowledge that it was a mistake and move on. You have to always prioritize the group, what's in the group's best interest, not any one person, not yourself, but the overall group. You have to think big. What can we accomplish? I mean, we have a finite time where we have the opportunity to leverage some of these assets. And in that period of time, what's the most that we can accomplish? And then finally, you have to obviously enjoy the process. So meeting the challenges of the time. So when I was a medical student at the University of Michigan, Jim Stanley was the division chief there, and vascular surgery was a relatively new concept as a distinct specialty. And Dr. Stanley gets credited for being one of the leaders of the idea that vascular surgery is unique and should be recognized as such. And I've taken that lesson to heart throughout my career. As a surgical resident at the University of Washington, Gene Strandis was a real leader in non-invasive vascular imaging and physiologic assessment of vascular disease. The idea that vascular surgeons could be surgeon scientists and understanding the hemodynamics of blood flow, and I took a lot of lessons from that. Oregon Health Sciences University, did my fellowship with John Porter, who had extremely high expectations for surgical outcome and quality, and is very demanding in terms of performance expectations. And obviously for the experienced surgeons in the group, we understand that in vascular surgery, that's really an imperative. And then, Julie Freischlag has been like a lifelong mentor for me, and understanding how to manage in challenging circumstances. Julie has demonstrated herself over and over again to be successful in a wide variety of challenging environments, where she's often a leader, first surgeon, first vascular surgeon, first woman, and really has established herself as credible in that area. So, those principles about how to succeed in academic surgery, I think, are timeless. They worked well before I was trying to build my own career. They've worked well for me in the context of my leadership opportunities, and I'm pretty confident they'll continue to work well in the future. And so I would encourage everyone to think a little bit about where you want to go, what opportunities you want to pursue, and how you can leverage your interests, your strengths, your connections to really help yourself and those who work with you succeed. So I very much appreciate the opportunity to present this experience to your group today. And hopefully sometime in the future, we'll be able to meet with everybody in person. Thank you very much.
Thank you very much indeed, Ron. I've got a whole page of notes, things that I wish I knew then, what you just taught me now. So really appreciate that. So there's an opportunity to ask Dr. Dalman questions. You can join by the web. We're going to run that banner. Go to polev.com, enter DeBakey, and respond to the questions that occur. That's on the by text. You can also do it, text DeBakey to 37607 and text in your message. And while we're getting those up, let me kick this off, Ron. So one of the hot topics here at the moment is, how do we pay for the academic component of an academic surgeon's day-to-day activity? I mean, do you guys have academic RVUs, or do you have protected time that may perhaps differ depending upon whether you're an assistant professor, associate professor, full professor? How do you do it?
Well, Alan, as you know, if you've seen one academic medical center, you've seen one academic medical center. So the funding systems vary from place to place. We have, I'm sure you do as well, we have different faculty lines. Some have an expectation of academic production. Some are more focused on clinical care and teaching. And so, there's that component that not everyone has the same expectations that way. We also have a 5-page detailed comp plan that reimburses people for submitting grants, for publishing papers. The reimbursements vary based on the citation index of the journals in which those papers are published. One Nature paper, for example, is worth about 5 Journal of Vascular Surgery papers. So, I mean, fortunately, and that's where the growth comes in. If you have a growing practice and growing RVU productivity and increasing profitability, that gives you the flexibility of deciding how to use some of that profit to reward other activities within your division. When I started as division chief, the department chair had one specific goal for me. He said, vascular surgery has to be profitable within 3 years, because it wasn't at that time. And that comes first. And once that's there, then you can decide how to invest those resources in some of the goals that you want to achieve.
Very good. So one of the unique, but it was not by chance, it's by design. The structures around Stanford is the level of innovation that occurs coming out of Stanford and coming out of the Bay Area. I mean, can you this is something that we would really like to emulate. As you know, Bobby Robbins came from Stanford, came here, and his entire focus was on development of the innovation infrastructure, and a lot of this was trying to copy what had been done at Stanford. But can you talk a little bit about how this evolved and how you as the division leader kind of take advantage of that infrastructure?
Yeah, so that's an excellent question, Alan, and a lot of people wonder why that is. And that's a complex answer, multi-layer, multi-generational. In both technology and biomedical research, a lot of energy and critical mass in the Bay Area. In terms of the talent that is attracted here, capital that's available for investment here. A lot of the venture firms and have interests in med tech investment. There are Stanford sponsors a huge number of med tech conferences. We have lecture series, and we have this biodesign program. I mean, I would say the short answer to that question is that's not something that can be, I don't think, developed through just one division or one department, but it needs to be kind of an institution-wide focus. And, we have an Office of Technology Licensing that's very helpful in terms of providing funding and, establishing IP and connecting with, business incubators. Dr. Fogarty obviously had many skills in that area with Fogarty Engineering as a business incubator. I think, it depends on, as I said, if you go back to the dean's principles for preeminence, it starts with the research part. And I think Houston Methodist, Stanford, there's a few places where research is really prized and rewarded. And I think, it's important as clinical investigators for us to help those decision makers understand that research for us is not just a matter of case series, but developing new devices, new care pathways, medical interventions. As I said, discovery science. It's hard to distill that question down to a single answer. It's a cultural thing, Ellen, and I think from what I can see, I mean, your group and your organization is doing that quite effectively. Well, how much Bobby contributed to that, I'm not sure. He told me his responsibilities are mostly around security and parking down there. But certainly that's an important question, and
Well, it's about vision, and I'll tell you a funny story. When the president of Texas Medical Center, we always describe as a little bit like the Queen of England. You give them the Buckingham Palace, but they smile and they wave, but they don't make policy. And clearly, Bobby was not a guy who was going to be happy with that role. In fact, one of the cardiac surgeons here sent him 13 black roses and said, "You're a dead man. Why would you take this job?" But he recognized that parking generates like $1 billion a year here, and that was under his control. And he used that actually to develop, this innovation infrastructure. In fact, one of the things he did was open a restaurant called the Third Coast, and the whole idea is, there's the Bay Area, there's the Boston area, the Third Coast is going to be down on the Gulf Coast, and so he had a huge impact on the direction of this. So,
well, that's good. I'm impressed. I'll have to congratulate him next time I see him about that.
Yeah, so please do. Okay, a question for you is: as a young vascular trainee, what are some of the things to keep in mind to set up a successful career? I think you've covered a lot of those, but how do you navigate and move up the ranks in an academic practice?
Well, again, I think it's a matter of understanding yourself and looking for opportunities. And I would encourage people to look outside of the department. Try to go to some of these conferences if you have time. For example, our Cardiovascular Institute has a biannual speed dating kind of event where new faculty members get 3 minutes to talk about what they're interested in. Just kind of go through quickly a series of presentations. And if you can attend events like that, you get a better idea about who's doing what. And, you have to have some insight into how you can be a valuable collaborator. You can't just say, hey, I got some specimens if somebody wants to test them. You have to bring some disease knowledge and some fundamental understanding of what's possible or what's current or relevant or where the important questions are in your area of interest. But I think the most important thing is finding collaborators who can help you, kind of balance your skills and interests with complementary skills and interests that most surgeons don't have. And I think that's probably the single most important thing.
Yeah, if I can add to that, I'd say you really only get to control two things early on, and that is where you work and who you work with. And it's important to choose the right organization and the right people. And one of the things I've learned, for example, taking the innovation world, somebody like Fred Moll helped start Intuitive Surgery. These people are serially successful. And it's the same thing happens whether you're in vascular surgery or cardiology. Find the people who've been serially successful, in building programs and grooming, the younger trainees. Let me close with one other question, Ron, probably the thing that piqued my interest most. The 5-page comp plan that you have in Stanford. And it sounds like this is pretty granular in terms of the academics that are being recognized. Yeah.
So the background for that is the Dean's office has been concerned about equity and compensation. And they, over the years, have asked for more and more granularity in terms of exactly how people are being rewarded. And so, on the one hand, being a division chief, I'm sure you understand, Alan, you have the single best knowledge about who's doing what and how valuable it is. And so I kind of resented the fact that Big Brother's looking over my shoulder to kind of micromanage how people are being reimbursed. But on the other hand, using that mandate to codify a lot of those activities and then making it, making it transparent across the division helps people align their efforts with what you want them to do. So, we have an annual counseling process and we meet with everybody and we say, this is what we talked about last year, this you did or didn't achieve these things, here's what we want to do next year. But in the background of that, the more granularity that you can put into your compensation plan, I think the more clarity your faculty have in terms of, how to move forward and how to succeed. And, so Dr. Jason Lee's taking over as division chief here starting next month. One of the first things he's going to do is we're going to have a retreat on compensation. We're going to break down our existing comp plan, paragraph by paragraph. And we still want to do this or not? Yeah. Does a new leader want to move in a different direction? So, that's, I think, appropriate. But I think there's a lot of value actually now. I mean, I was very skeptical and a little bit resentful of this process at the beginning, but I would say now I think there's a lot of value in that. It's very useful, and it does provide transparency and granularity. And we can say with confidence that the women are being paid as much as the men, and we can say that meeting certain metrics will result in significant financial rewards. That I think is valuable, so it's worth considering.
Well, Ron, thank you. I hope everybody else enjoyed it as much as I did and learned as much. So I really appreciate you sharing this wisdom with us. Thank you.
Thank you, Alan. Thanks, everybody. Thanks for the invitation and good luck with everything. Okay.
Appreciate it.